Electrical impedance tomography in assessing ventilation and perfusion, mostly in patients with ARDS, in which this technique has a major application. These are my conflict of interests, nothing actually related to the topic today. So, electrical impedance tomography is a non-invasive, radiation-free technique in which a belt is placed around the thorax. Depending on the brand, it can be a different number of electrodes, and essentially it allows the measurement of the electrical impedance of the thorax that obviously can change according to different degrees of aeration or movement of fluids inside the thorax. And what is really interesting in this technique is that if you see the top signal, this is the signal that can be seen on a conventional EIT monitoring tool. It provides information about the change in volume related to tidal volume. You see the so-called delta Z, and this corresponds to obviously a change in pressure in the airways, as you see in the tracing at the bottom, but also it tells you and provides information in terms of absolute changes in lung volume related to changes in positive end expiratory pressure. You see that after 10 seconds, the PEEP is increased by 5 centimeters of water, and this generates a change in the signal, which is correspond to a change in the end expiratory lung volume that is caused by the change in PEEP. And this is something really intriguing because we are looking for tools to assess whether our change in PEEP provides sufficient volume, change in volume, and to define adequate alveolar recruitment and maybe say that PEEP is beneficial for the individual patient. So this initial slide tells you that the EIT is a tool that may really help the customization of care for ARDS patients. And you will see that this can be done both in terms of tidal volume and in terms of positive end expiratory pressure. And this is another signal and another view of the point, because you see this patient is ventilated with PEEP 5 centimeter of water, then the PEEP is increased to 15 centimeter of water, and you clearly see that there is a shift in the gas volume from the anterior to the posterior part of the lungs that is actually the real objective of PEEP, and this is recruitment. And this slide tells you something really peculiar for the role of EIT in management of ARDS patients, because this tells you that EIT does not provide only an information about what happens in the entire lung, but it can provide you regional information about the inflation of the lung and the effect of the interventions that you are applying. So, obviously, the EIT provides some crude signal, and we need methods to interpret the data that this signal provides. And the first is description of a method to define the regional overdistension and collapse provided by PEEP in ARDS patients comes from the group of Marcelo Amato, who was actually one of the inventors of this technique. And essentially, if you look at the panel A on the left, you see that actually the EIT can provide information about different pixels of the image. And you can have a pixel A, which is in the most non-dependent region, so the ventral part of the lung, and the pixel B, which is, for instance, in the dorsal part of the lung. Well, the compliance of that pixel can be calculated by the change in electrical impedance signal, so the delta Z in that pixel provided by tidal volume divided by the driving pressure, which is constant. And this can be done, if you see the lower figure, during a decremental PEEP trial, and you will clearly see that the behavior of the two pixels is different, because the pixel, the black pixel, which is the one in the most ventral part of the lungs, has a best compliance, so optimal mechanic for that pixel in the at a lower PEEP, so between 7 and 9 in this case. While the pixel in the dorsal part of the lung, being essentially collapsed, requires a PEEP of 15 to reach its optimal compliance, its optimal individual compliance. Then, if we go to the following figure, we can essentially define for that pixel the entity of overdistension and collapse according to the ratio of the compliance measure for each PEEP level for that pixel divided by the optimal compliance for that pixel observed in the PEEP trial. So, making a long story short, essentially it is possible to make an average of what happens in the entire lung in terms of collapse and overdistension, and then assess which is the best balance between collapse and overdistension for the lungs in terms of pixel-per-pixel basis. And what is interesting is that this method can be applied also during pressure support ventilation, when the driving pressure that is used for the calculation is essentially the sum of the inspiratory pressure applied on the ventilator, so the first panel, and the negative deflection in the esophageal pressure, as Liz showed before. And the sum of the two generates the dynamic transpulmonary pressure, and this permits to do a PEEP trial and to determine which is the optimal compliance, which is the optimal PEEP to best balance between regional overdistension and collapse during pressure support ventilation. However, this way to set PEEP and to balance between hyperdistension and collapse starts for the assumption that the best PEEP for the individual pixel is the one corresponding to the best compliance of that pixel, which is obviously something physiologically reasonable, but still an assumption. And there are other ways to see the problem in terms of mechanics. And one point could be essentially to target a way of targeting a PEEP that allows the ventilation to be as balanced as possible between the ventral and the dorsal regions. And you see this can be easily calculated also from visual inspection of the signal. In this patient, you have, this is called the center of ventilation, and you clearly see that the point of PEEP in which the ventilation, the center of ventilation is more close to the center of the lungs is the one corresponding to PEEP 12. And what is interesting is that this center of ventilation, if you try to set PEEP based on a decremental PEEP trial and targeting a center of ventilation right in the middle of the lung, you may have a PEEP which is slightly lower than the one corresponding to the maximal compliance. And this again raises the issue whether the maximal compliance could be a physiological approach to set PEEP in ARDS, which is a debated matter. But EIT can be used also to assess ventilation and perfusion and the balance between ventilation and perfusion. To do so, you just have to consider that the EIT is a tool that provides information about the overall impedance of the thorax. If you perform an end-inspiratory occlusion, so you removed all the role related to ventilation, so you keep the patient apneic during an end-inspiratory hold, and you provide a bolus of saline solution of 10 milliliters, this is a pertonic saline solution, you will see changes related to the perfusion of the lungs. And as you can see on the left, you can reconstruct the map of perfusion that once overlap to those of ventilation obtained in the breaths before, can provide essentially a balance between ventilation and perfusion and information related to the amount of shunt and dead space that are present in the lungs. And if you see here, the behavior in these 7 COVID-19 patients was actually heterogeneous. And you see that maybe COVID-19 is a particular disease in which the dead space fraction and related to ventilator perfusion mismatch can be very high, but still this technique allows to provide information about this. And more importantly, this technique can allow you to, by assessing ventilation and perfusion at 2 levels of PEEP, permits to assess the response to the different interventions applied in terms of changing matching of ventilation and perfusion. And this has been recently shown by the group of Tommaso Mauri and Antonio Pesenti, in which, in a study in which they actually showed that it is possible to determine the effect of PEEP in terms of ventilation and perfusion matching in patients with ARDS with this technique. And interestingly, the change in wasted perfusion and wasted ventilation caused by PEEP. So the aim of PEEP obviously is to reduce the amount of wasted ventilation, so ventilation of alveoli that are not perfused, at the same time to limit the amount of wasted perfusion, so to limit the amount of perfusion or of alveoli that are not ventilated. And you clearly see that the change in wasted ventilation and perfusion is related to the recruitability assessed with a simple maneuver, which is the recruitment inflation ratio. We spoke so far about about controlled mechanical ventilation, but actually it is really actually possible to use this technique also in patients who are spontaneously breathing. And this is very intriguing because this technique was firstly used by Takeshi Yoshida to describe one phenomenon whose importance in determining the risk of self-inflicted lung injury is quite relevant, which is the pendulum phenomenon. This is a patient, an animal model in which ARDS was induced, and you have the EIT signal for the different zone of interest. So the most ventral part of the lung, zone 1, to the most dorsal part of the lung. You have on top airway pressure flow tracings. This is pressure assist control ventilation. And you see here that in the first part of the slide, the left part, the spontaneous breathing is maintained, while in the right part, the spontaneous breathing is abolished by muscle paralysis. And in the presence of spontaneous breathing, you see at the very beginning of inspiration that the behavior of the different areas of the lungs is different. So the most ventral part of the lungs suffer from a deflation in the air. So they deflate during inspiration to inflate the dorsal part of the lungs. And this is quite weird because this means that in some patients there can be a deflation at the beginning of expiration in the ventral part of the lungs, which goes, and this air goes from the ventral part of the lung to the dorsal part of the lungs. And when you measure the tidal volume does not inform you about this because this is a shift of gas which occurs inside the lungs independently from the volume that you get from the ventilator. And these end up generating overdistension in the dorsal part of the lungs. And this is why patient self-inflicted lung injury is different from ventilator-induced lung injury. Ventilator-induced lung injury occurs in the ventral baby lung, while self-inflicted lung injury mostly involves the dorsal part of the lungs. And this is the classical image that tells you about this phenomenon in patients with spontaneous breathing. You see here that the inflation is completely, at the beginning it was completely inhomogeneous, first in the dorsal part of the lung and after in the ventral part of the lung, while this becomes completely uniform once pressure control is established, abolishing spontaneous breathing. I will go to this one, and this not only involves patients who are spontaneously breathing while intubated, so under pressure support ventilation, but may involve also patients who are spontaneously breathing under non-invasive support. I take the example of these patients treated with the high-flow nasal oxygen. You have on top the airway pressure and the...
Domenico, you have 1 minute left.
Yes, I'm done.
Thank
you. You know, yeah, I'm sure that when I was going to the helmet, I would have been stopped. Anyhow, you see that there is quite an inspiratory effort, and you see that at the bottom line, there is a deflation in the ventral part of the lung and inflation in the dorsal part of the lung, so a Pendeluft phenomenon, which can be controlled by the application of PEEP, which makes the inflation more uniform. So this takes to my conclusion, and I think that EIT is a physiologically based, bedside, radiation-free, reproducible monitoring tool to assess regional ventilation and perfusion. It's been used mostly for research purposes so far, but it has really important clinical perspectives in terms of customization of care, so to individualize PEEP, monitor tidal volume size and distribution, and assessing the response to specific interventions in ARDS patients. Thank you very much.